Welcome, and thank you for attending Evaluation of Biotoxin Induced Chronic Inflammation. I am Dr. Lily Lu Wing, and I will act as your moderator. As your moderator, I will assist in the live chat and Q&A throughout the presentation, and following the presentation, we will have allowed approximately 15 minutes for the live Q&A. Attendees are in listening mode, so please submit your questions in the virtual Q&A or chat applications. The recording and slides will be available to participants the next day. The content of this webinar is for educational and informational purposes only. The information is not to be interpreted or mistaken for clinical advice. Please consult a medical provider or a healthcare provider for the medical advice, diagnosis, or treatment. And now let me introduce you to today's presenters, Brooke Mader and Dr. Jason Barker, who are our clinical lab educators here at Vibrant America. Brooke Mader is a clinical nutritionist, board-certified nutrition specialist, and a professional member of the American Nutrition Association. She received her Master's of Science degree in clinical nutrition at Maryland University of Integrative Health, and she continues to mentor graduate students from MUIH. Dr. Jason Barker graduated from Southwest College of Naturopathic Medicine. He earned his BS in Exercise and Sports Science with a minor in Anatomy and Neurobiology from Colorado State University. After obtaining his doctorate in naturopathic medicine, he completed a 2-year residency at National University of Natural Medicine and earned a certificate in clinical research at Oregon Health and Sciences University. He has been in clinical practice for the last 21 years while serving as a clinical consultant to the nutraceutical and sports medicine industry. He has authored numerous articles for several functional medicine journals and currently resides in Colorado. Now I'm going to pass it over to you, Brooke.
Thank you for the sweet welcome, Lily. Today, we will be discussing the immunologic overview of biotoxin-induced illness, causes and clinical manifestations of biotoxin illness. We will discuss which type of cases and patients you should use the Chronic Inflammatory Panel on, and a complete overview of test analytes and what to look for. Biotoxin-induced chronic inflammation is the body's out-of-control inflammatory response to a toxin that it can't detox on its own without treatment, and then causes a cascade of inflammatory and hormonal changes. Most of what we know about biotoxin in illness, also referred to as Chronic Inflammatory Response Syndrome, or CIRS, comes from the researcher Dr. Richie Shoemaker. Dr. Shoemaker started studying CIRS in the late 1990s and coined the term to describe when a body's immune system is not functioning properly. Biotoxin-induced illness is a progressive, multi-symptom illness characterized by exposure to biotoxins. The ongoing inflammation can affect virtually any organ system of the body, and if left untreated, can become debilitating. Biotoxin-induced chronic inflammation starts when a person is exposed to a biotoxin. Biotoxins are a group of substances that are toxic to humans and biological in nature. They can be made by plants, bacteria, fungi, or animals. For example, biotoxins can be mold, tick-borne diseases, spider bites, viral and bacterial infections, chemicals, and other toxins. Once you are exposed to a biotoxin, the immune system flags the invader and works to have it broken down and removed. If someone is exposed repeatedly or in excessive amounts, which can happen when someone either lives in a moldy home or works in a moldy environment, the biotoxin can't fully be removed and sets off a series of inflammatory responses throughout the body. For many people, biotoxins are recognized by the immune system correctly. They're broken down and removed from the body. However, some people have the HLA gene, which makes them more susceptible to biotoxins. Although anyone can be impacted by biotoxins, those who are genetically susceptible are much more sensitive, and their immune system can't recognize the biotoxin, and so it doesn't remove it. It leaves the biotoxin circulating in the body, causing inflammation. Most biotoxins are extremely small, fat-soluble molecules, which are capable of passing from cell to cell through cell membranes without being carried in the bloodstream. Biotoxins can enter through inhalation, direct contact with contaminated water, ingestion, tick bites, and spider bites. This makes it really difficult and sometimes impossible to find in standard blood tests. To look for biotoxins and make a diagnosis in cases of biotoxin-related illness, we have to look for the evidence of the damage that the biotoxins cause in various body systems, especially the immune system. And Vibrant has a comprehensive set of analytes we use to find the evidence we need to determine that biotoxins are involved. Once biotoxins are present in the body, they set off a complex cascade of biochemical events. The biotoxin binds to toll-like receptors, which results in the production of cytokines, which are involved in the upregulation of multiple inflammatory pathways. This starts the biotoxin pathway and eventually leads to this multi-symptom, multi-system illness. However, because of the wide array of symptoms, it often leads to misdiagnoses and suffering. Symptoms can appear random at first, but they do have some commonalities. Some common misdiagnoses of biotoxin-induced illness are chronic fatigue syndrome, fibromyalgia, Alzheimer's, PTSD, depression, allergies, and even ADD and IBS. For most people, the immune system tags biotoxins as foreign invaders. They are then broken down and cleared from the body through the liver. But for some people with a genetic susceptibility, their body is unable to identify and tag the biotoxins for elimination, so they just continue to circulate. The innate immune system is the first non-specific responder. It involves cytokines, macrophages, and neutrophils. The innate immune system results in the classic symptoms associated with inflammation, like heat, pain, redness, and swelling. The adaptive immune system is slower, more targeted, and much more sophisticated. It includes T cells and B cells, which are very important when it comes to having a precise response to a threat. T cells receive information from the innate immune side by antigen-presenting cells, which are specialized immune cells that encounter the threat, and they take a small molecular snip called an epitope, and they absorb it and then present it to the T cell. Once the T cell is turned on, natural killer cell activity upregulates, and then the T cell begins to trigger B cells, and B cells make antibodies, and these antibodies create a more specific response to the threat, and they create memory cells. Biotoxin-induced illness actually falls into primarily the innate immune system. And one of the major problems is that there's an inefficient handoff between the innate and the adaptive immune system. It's basically a defect in antigen-presenting cells. And this means once the innate immune system is triggered and inflammation is generated, there's no real transition to adaptive immunity. So we don't see a large cell-mediated response, meaning there is no upregulation of T cells, as well as inefficient antibody production. So these patients remain stuck on the innate side of the immune system, which can be a cytokine storm. Because there is no triggering of the adaptive immune system, you will not see elevations of traditional markers. You won't see increased SED rate or CRP. This is not an autoimmune disease. Instead, you will see upregulations of key innate elements, which we will be going into in more depth. So just to recap, the innate immune system. Do you not see my screen anymore?
It went away for a second.
Can you see it now?
Perfect. Thank you.
All right. So the innate immune system is the first responder. Biotoxin illness is the result of the innate immune system staying on and not maturing into the adaptive immune response. Normally, innate immunity should hand off to the adaptive immune system, but in this case, there's an inefficient handoff between the two sides of the immune system, and these patients remain stuck on the innate side. The disease is the chronic inflammation itself, not the exposure. This is the biotoxin symptom clusters. By definition, a patient needs to meet a multi-system, multi-symptom screening analysis. And when performed correctly, the cluster analysis has an accuracy of 95% in identifying patients that are at risk for biotoxin-induced illness. There are 13 categories or clusters. And if an adult presents with at least one symptom in at least 8 of the 13 clusters, this is considered consistent with biotoxin illness. And if a child presents with at least one symptom in at least 6 of the 13 clusters, this is considered positive. It is essential to document all of the symptoms the patient is experiencing and medical history, along with any history of known exposure to common sources of biotoxins. Here are a list of questions to ask patients who have been exposed to biotoxins. For those who have been exposed to water-damaged buildings or mold, you should ask, do you or did you live in a building with obvious mold visible? Has your home ever been flooded? Does your home have condensation on the windows? Are there any water stains around light fixtures on your ceilings? Did you feel worse after you moved homes, schools, or even a workplace? Has conventional air quality testing revealed mold spores present? Do you smell musty odors in your home? Other questions can include, have you had a tick bite, followed by severe flu-like symptoms that persisted after visiting a Lyme endemic area? Have you been exposed to or swam in a body of water with an algae bloom? Have you eaten reef fish and felt ill soon afterward? Have you ever had a spider bite from a brown recluse spider? And after collecting all of this information, we then move on to a comprehensive list of tests. Most people probably have had extensive lab tests done at this point. However, tests for biotoxin-induced illness specifically look at how your immune system is responding to a biotoxin. The test can indicate if your innate immune system is being overstimulated. Vibrant's Chronic Inflammatory Panel has 3 main sections: the inflammation and associated markers, hormones and associated markers, and bleeding associated markers. This test is a great starting point for measuring key analytes that become imbalanced in biotoxin illness, and also serves as a way to measure patient progress during treatment. This is a snapshot of the inflammation and associated markers section of the report. There are 4 main inflammatory markers used in the diagnosis of biotoxin-induced illness, and they are TGF-beta1, MMP9, C3A, and C4A. Typically, at least one of these inflammatory markers will be excessively high, and in most cases, 3 or more of them will be excessively high. And we're going to start off by reviewing each of the 6 analytes in this section. So VEGF, this is a signal protein, and it is produced by the body to stimulate the growth of new blood vessels. Under normal conditions, the body makes VEGF in response to low oxygen levels. So when tissues receive too little oxygen-rich blood flow, then VEGF is produced to provide a better blood supply to the tissues. In biotoxin-induced illness, VEGF is suppressed due to increased levels of cytokines, which can trigger an accumulation of white blood cells in the capillaries. And this leads to restricted blood flow and lower oxygen levels to the tissues, which is called capillary hypoperfusion. When we get a decreased amount of new blood vessels, our oxygen supply decreases. Symptoms of reduced VEGF lead to fatigue, muscle cramps, and shortness of breath. Because without proper blood flow, cells begin to starve and don't work properly. Mold can lower VEGF, and exercise can actually increase it. But in the very, very early stages, VEGF can be increased, signifying that the body is trying to compensate for low oxygen delivery to tissues. VIP is an important neuropeptide produced in many places in the body, but most well known in the gut, pancreas, and the brain. It helps regulate inflammation throughout the body, so it's an important immune modulator. VIP also helps to regulate blood flow to the pulmonary artery, which is the artery that moves blood from the heart to the lungs to pick up oxygen. And in patients with low VIP levels, pressure in the pulmonary artery builds and causes shortness of breath. Low levels lead to poor regulation of inflammation, shortness of breath, and chemical sensitivities. Some studies have found that restoring appropriate levels of VIP is crucial for down-regulating the systemic immune response, and it can be used therapeutically as part of a treatment protocol to help restore energy in chronically fatigued patients. So if a patient remains symptomatic after following a treatment plan, then the use of VIP can be considered to help down-regulate the immune system. It is a nasal spray available from compounding pharmacies, and it's administered intranasally. It is important to use this only once the biotoxin has been cleared out, because if it's used too early in the treatment process, it can actually make things worse. Dr. Diane Mueller is an amazing doctor, an author, and survivor of biotoxin-induced illness. She recommends a dose of around 50 micrograms intranasally 4 times a day. Oftentimes with mold illness, we get changes in the brain, and intranasal VIP may help repair the brain from some of the damage. And according to Dr. Shoemaker's paper, published in 2013, administration of VIP may correct C4A, TGF-beta1, VEGF, MMP9, estradiol, and testosterone. But more importantly, though, it may improve the quality of life. TGF-beta1 is another inflammatory marker. It is a complex protein that has the ability to both increase inflammation or decrease inflammation, depending on the body's condition. It helps cells mature and change into other cell types, which is how it gets its name, transforming growth factor. When TGF-beta1 is in the normal range, it keeps balance between the side of our immune system that needs to be alert to fight an intruder, but yet not to be so active that our immune system attacks our own tissue. This control is managed by T regulatory cells and T helper cells. When elevated, an imbalanced innate adaptive immune response is likely. And elevated levels of TGF-beta1 are correlated to inflammation and a disease state because TGF-beta1 signals our body to keep making cells to fight the intruder. And they also have a positive feedback and stimulate the production of even more TGF-beta. So elevated levels can also lead to remodeling of tissue in the lung, leading to shortness of breath again, and asthma-like symptoms, and other organs in the body like the liver, heart, and kidney can also be affected. MMP9 is a zinc-dependent enzyme. It's produced by activated immune cells and released by the innate immune system. It's involved in the body's natural process of tissue repair and replacement and normal tissue growth, such as blood vessel creation, ovulation, wound healing, and bone formation. In biotoxin illness, cytokines trigger certain white blood cells to release MMP9 into the bloodstream, and it's responsible for increasing permeability, which allows inflammatory compounds to pass more readily out of blood vessels and into the lungs, brain, muscle tissue, nerves, and joints. Although this is needed and really important in acute injuries, it can be very dangerous long-term as it can exacerbate disease progression. And because cytokine activity increases MMP9 production, MMP9 is an excellent marker of hidden cytokine production. Both C3A and C4A are part of one branch of the innate immune system called the complement pathway. The complement pathway assists the immune system in helping destroy foreign invaders. In order to produce C3A, there needs to be a microbial cell membrane present, which means C3A is more specific to bacterial infections, such as tick-borne illnesses. Since mold and Lyme patients are often indistinguishable based on symptoms and physical exam alone, C3A can be a very helpful marker that tells us whether there is a tick-borne disease involved. So when elevated, Lyme disease should be considered. And C3A usually is elevated within 12 hours of a tick bite. And like C3A, C4A, also part of the complement pathway, which means it assists the immune system in helping destroy foreign invaders. Once activated, the production of C4A can become self-reinforcing, which is a process known as autoactivation. And what this means is a patient who has been exposed to a water-damaged building can have continually high levels of C4A even after they get into a clean environment because of the process of autoactivation. So basically, removal from exposure does not stop production of C4A. C4A can remain high even after removal of exposure. And in case you are a visual person, this may help you understand this a little bit better, but high C4A with low C3A may indicate a biotoxin burden is present. And a high C4A with a high C3A may indicate an infection is present. Now we're going to go to Dr. Barker, who's going to review the next 6 analytes of the Chronic Inflammatory Panel.
All right, thank you, Brooke. I'm Dr. Jason Barker, and I am going to review the remaining 6 analytes on the Chronic Inflammatory Panel, 3 of which are hormonal markers, and then the other 3 are associated with bleeding. Now, the 3 hormonal markers that we're going to look at are antidiuretic hormone, ADH, adrenocorticotropic hormone, ACTH, and melanocyte-stimulating hormone, MSH. Now, I want to start off with melanocyte-stimulating hormone because it's such an important hormone in biotoxin illness. And as one top clinician in the research field of biotoxin illness put it as the most important hormone you've never heard of. Now, I can agree with this because after, I don't recall hearing about this one in school much or in any of my studies until I started researching and learning about biotoxin illness. And if you think about it, those of us in the clinical field, we're all focused on treating thyroid hormone, adrenal hormones, reproductive hormones, but you don't hear about this one very much. But as we'll discover tonight, it's super important, especially in biotoxin illness. So MSH is a neuroregulatory peptide. It functions as a master control hormone with several different functions. and it's created from a compound known as pro-opiomelanocortin, or POMC, in the hypothalamus. And what happens is this POMC compound splits, it gets cleaved into MSH, it gets cleaved into adrenocorticotropic hormone, and also into endorphins. Now, with MSH, it has several important functions. It's probably the most critically suppressed hormone as part of the dysregulation that we see in biotoxin illness. And in the research, it's estimated that 95% of people suffering with biotoxin illness have reduced MSH levels. So firstly, it's a highly potent anti-inflammatory compound. It regulates the innate immune system, and as Brooke addressed, when the brain is under cytokine attack, it cannot continue with that regulatory role over the innate immune system. Now, when MSH is low, we'll see just some very general symptoms to start off with. Headaches, sometimes these are like very sharp headaches, brain fog, chronic fatigue, sleep disruption, and chronic pain, just to name a few. Now, another role of MSH is that it supports and regulates several other hormones in the body, namely antidiuretic hormone, adrenocorticotropic hormone, vasoactive intestinal peptide that we heard about earlier, and it can even exert influence over our reproductive hormones. As an example, when MSH decreases, we'll see an elevation in the enzyme aromatase, which then converts androgens over into estrogens. So we can see hormonal imbalance all alone, distant from MSH dysfunction. Now, one of the most important roles that MSH carries out is it is in charge of mucous membrane based immune defenses. So one thing that we'll see in people who are suffering from biotoxin illness is that they can become more vulnerable to a sort of opportunistic infection. And this is known as MARCONS, and that's an acronym for multiple antibiotic resistant coagulase negative staph. So that's multiple antibiotic resistant coagulase negative staph. I'm repeating that because it's not on the slide there. But what happens is MARCONS isn't necessarily a symptomatic infection, but it does occupy the spaces in the deep nasal cavities. And the problem with MARCONS is that it releases exotoxins, which directly destroy MSH. And so as that MSH continues to decline, the body loses control over those mucous membrane defenses. Now the MARCONS can create biofilms so that the rest of the immune system is unable to take care of this infection. So as part of treatment of biotoxin illness, you have to get rid of the MARCONS, and that's usually done with a combination product of a chelating agent and a couple of different antibiotics. Now, MARCONS also releases hemolysins, which are compounds that disrupt red blood cells. It damages endothelial cell membranes, allowing for increased inflammation, increases coagulation risk, and even causes some antiphospholipid abnormalities that we'll cover when we look at the bleeding markers. Now, as an aside, as MSH falls, we'll also see an increase in intestinal permeability. So it's important to discern when you have your patient who comes into the clinic and you've done your workup and you've deduced that they have intestinal permeability or leaky gut. These patients who have this, who have biotoxin illness that you don't quite know about yet, you can give them all the glutamine in the world. You can do all of the leaky gut treatments that you want, but they are not going to improve. And so this is a good instance when your regular protocols aren't working with something like leaky gut, to start looking for deeper causes and perhaps taking a look at whether they've got biotoxin illness using this chronic inflammatory panel. Now, another thing that we see is that when the MSH is not initially cleaved off of that pro-opiomelanocortin molecule, we also see a decrease in creation of endorphins. So one thing that you'll see in patients who have biotoxin illness is that they just have a lot of chronic pain. And again, this is pain that is very difficult to pin down. The typical inflammatory markers don't really let you know about this. So again, taking a look whether they've got biotoxin illness using something like this chronic inflammatory panel is a good idea. Now, next question is, how did MSH get low in the first place? Well, if we go back to the hypothalamus, normally what happens is when leptin binds to its receptors in the hypothalamus, this also stimulates cleavage of the POMC molecule into the adrenocorticotropic hormone, MSH, and the endorphins. But because the brain and the rest of the body is under attack essentially from so many of these cytokines from the innate immune system, those leptin receptors become occupied, and now the patient has leptin resistance effectively. So this is also one reason why you see some of this refractory weight gain in people suffering from biotoxin illness, is because they are leptin resistant. Okay, next hormone is antidiuretic hormone. So a real quick physiology recap. Antidiuretic hormone prevents diuresis. So as blood osmolality increases, we release more antidiuretic hormone to hold on to more water to hopefully lower that blood osmolality. And then the reverse is true as well. As the osmolality increases, we create more of the antidiuretic hormone so that we can hold on to that water to lower that osmolality down. Now, in people with biotoxin illness, there's a dysregulation in the system. ADH and osmolality don't necessarily sync up like they would in a healthy person. Now, initially in biotoxin illness, ADH levels can be increased, and this will cause things like fluid retention, edema, and of course, weight gain. This is an instance where maybe you have a patient who presents to your clinic and they say, hey, I've gained 20 or 30 pounds in 2 months. I haven't changed my exercise routine. I haven't changed my diet because they've got so much water weight on board. Now, as biotoxin illness progresses, and that MSH declines, we'll also see a decline in ADH. So now we have the opposite set of symptoms going on. And that is these people will report a lot of polyuria, a lot of nocturia. So they're getting rid of that water. They're very easily dehydrated. They'll have electrolyte imbalances. And of course, they'll have some muscle cramps with that. And now one of the more peculiar symptoms that you'll see in people who are extremely dehydrated with biotoxin illness is that they're prone to a lot of electrostatic shocks. And this is because they're so dehydrated and their blood is so concentrated, they start to push sodium and chloride out onto the cell, onto the skin surface. And this creates a battery-like effect, allowing them to get shocked at every turn where they go. Another thing that these patients will talk about is they'll say, I drink tons and tons of water all day long. I still feel thirsty. I still feel dehydrated, and that water just goes right through me. Now, in more extreme cases of ADH deficiency or imbalance, we'll have to give people a synthetic form of ADH known as desmopressin. This, of course, will help provide some balance, but at the same time, it's not curative. What has to happen is once that MSH becomes re-regulated up to normal levels, then you'll see this system start to balance out a little bit. Reference range down there, 1 to 3.3, and then you want to look for an osmolality around 280 to 300 for a normal range on the ADH. Now, the next hormone that we will look at is adrenocorticotropic hormone. And this, of course, influences the release of hormones from the adrenal glands. So it'll dictate release of cortisol, dehydroepiandrosterone, epinephrine, norepinephrine, and the mineral corticoids. Now, as a point of caution too, of course, when we have ACTH imbalance, you're going to see an imbalance in cortisol. And again, if you've got a patient who presents to your clinic with, say, chronic fatigue, they have unrestorative sleep, they are intolerant to stress, they have exercise intolerance, and you run some cortisol labs on them and they're low, and you say, aha, this patient has what we used to call adrenal fatigue, which is now known as HPA axis dysfunction. Well, you can treat these people all day long with all the B vitamins and the ashwagandha and the rhodiola and the ginseng and all the adrenal support, but you're not really going to see a resolution of those symptoms because, again, the problem is not in the adrenal gland. The problem is back upstream with that adrenocorticotropic hormone. So again, if you are treating people like this and your regular protocols are not working, perhaps start thinking about biotoxin illness and looking at these chronic inflammatory panels. Okay, now a few extra points about adrenocorticotropic hormone. It has a diurnal secretion, just like cortisol does, because it precedes cortisol levels. So you'll see higher levels in the early hours of the day, and then you'll see that attenuate as the day goes on, just like you would with cortisol. So just You can draw the blood on this lab at any time of the day, but really it'd be important to know when exactly your patient is having their blood drawn, just so you can correlate that time of day with these levels to make sure that things are equaled out, that they correlate. Now, a few cautionary statements about looking at ACTH and cortisol. If you have a very high ACTH and a high cortisol level, sometimes that can look like Cushing's disease. If you've got a high ACTH and a low cortisol, that can look like Addison's. And if you've got a low ACTH and a low cortisol, sometimes that can look like hypopituitarism. So just as a point of caution, make sure you discern those patterns when you're measuring these hormones, and just make sure that you're also not going after something like adrenal fatigue when you've got bigger backstream issues going on. Okay, now we're going to shift gears into the three final analytes, and these are the bleeding associated markers, and there's three of them. The first one is plasminogen activator inhibitor 1, and I'll refer to that as PI1. And then we'll look at anticardiolipins and then von Willebrand's profile. Now, plasminogen activator inhibitor 1, or PI1, it's a marker of increased coagulation. So it works by blocking the action of other plasminogen activators. So in short, you're going to see an increased risk of coagulation from this particular protein. This can raise your risk for widespread clotting, stroke, MI, and even DVT. So you don't necessarily always see this in biotoxin illness, but definitely if these markers are very high, that's something that needs to be taken into your clinical consideration. Now, looking at our next bleeding-associated marker, these are the anticardiolipin antibodies. And cardiolipins are essentially lipid molecules that play an important role in the blood clotting process. Some of the most common situations where you have anticardiolipin antibodies, something called antiphospholipid syndrome. You can also see this in various autoimmune diseases, and such as lupus, and also antiphospholipid syndrome, which I just mentioned. So with the anticardiolipin antibodies, it is important to know that they need to be very low. We like to see those numbers under 1. Cardiolipins are found in cell membranes. They're found in platelets in the highest concentrations, and they're also found on the inner membrane leaflet of the mitochondria. So if you have a large amount of these antibodies circulating, we can also see uncoupling of the electron transport chain in the mitochondria. And this is perhaps why these people with biotoxin illness experience such deep fatigue, is they're not making energy anymore in the mitochondria. Essentially, anticardiolipin antibodies can be considered an antimitochondrial antibody. And then as a treatment note, omega-6s are a direct precursor for cardiolipins. So we like to include those as part of the treatment and repair for those lipid molecules in the body. Now, moving on to the last one, von Willebrand's profile. Von Willebrand's factor is a protein that makes up, it's one of the components of the clotting cascade. And what it does is it helps make an adhesive bridge between platelets and an injury site. Now, von Willebrand's factor is one of several acute phase reactants. So you can see this one elevated with inflammation. As an aside, von Willebrand's disease is one of the most common inherited bleeding disorders. So this is not indicative of that, but rather what happens with biotoxin illness is that because those cytokines interfere with the action of this protein, what we'll see is an acquired von Willebrand syndrome. So this will resolve as that biotoxin illness resolves as well. But we like to see levels around 50 to 200. And then interestingly, with all of these clotting factors being out of balance and essentially dysfunctional, you'll see both hypercoagulability, like I spoke about earlier, that increased risk for clotting. And then you can also see some bleeding, and namely, you'll typically see that as mucosal surface bleeding, which can mean very hemorrhagic nosebleeds, and even women will wind up often with very, very heavy menses. So this is also something that would require a pretty extensive workup, but if there is no answer to that, then of course, considering if this person is suffering from biotoxin illness would be a good idea. Okay, that wraps up our analytes. And now when I want to shift gears a little bit and cover some symptoms and conditions that should make you think of biotoxin-induced illness. Now, Brooke addressed a few of these earlier. We've got a more extensive list here of several different conditions and symptoms. Interestingly, there's an 80% crossover in the symptoms involved in these conditions and the same symptoms that go on in biotoxin illness. And in fact, several researchers in the field of biotoxin illness think that many of these conditions may actually have their root origin in biotoxin illness. So as you see here, we've got pain from perhaps lack of endorphins. We've got that fatigue from those anticardiolipin antibodies. Of course, the weight gain, as an example, we talked about that antidiuretic hormone, leptin resistance, HPA axis dysfunction. Now you'll notice there's quite a few neurologic type symptoms and conditions here. Think about what's going on in the brain, essentially with all of those cytokines, that barrage of cytokines that's going on in the body. This affects the neurological system and the brain is essentially on fire. So it's interesting to think that perhaps some of this inflammation could precede some of these conditions that are going on here. Now I just want to go quick flashback to those symptom clusters that were shared earlier. Think about all of these symptoms and how there is that 80% correlation with some of these other conditions that we talked about earlier as well. Now, who should be tested for biotoxin illness? Now, these are the biggies right here, despite the ones that I just showed. Those should be in your differential as well. But the big ones are really people have been exposed to water damaged buildings. That's estimated to be about 80% of the cases. In fact, in 2011, the National Institute for Occupational Safety and Health reported that about 50% of buildings in our country have sustained water damage. That's not just high-rise buildings, that's homes as well. So quite a high risk with that. Of course, tick-borne illnesses, Brooke covered those as well. Think about your patients who have known tick contact or a known tick infection. They had erythema migrans, they were treated for Lyme disease. They seem to do better, but then they show up back in your clinic about 3 to 4 months later with all those same symptoms. Is that a reactivation of that tick-borne illness, or is this just that their innate immune system never turned off and it's more of a biotoxin illness? Of course, there are the dinoflagellates, ciguatera and Pfiesteria. These are a type of poisoning by fish and then also by a type of blue-green algae. And in fact, these are the original biotoxins that Dr. Shoemaker elucidated when he started developing his ideas about chronic inflammatory response syndrome. We mentioned brown recluse spiders also, but just remember, any living organism or a fragment of an organism that acts to trigger an innate immune response can function as a biotoxin. So keep in mind these big ones, but also do keep in mind these previous conditions, because remember, we see these people in clinic every day. They're fatigued, they've got weight gain, they've got headaches, they've got all these kind of amorphous symptoms. And if your regular protocols aren't working, perhaps start digging a little bit deeper and looking at whether it's a biotoxin illness that's contributing to that. Now then, very quickly, what biotoxin illness is not. It's not just about mold, as we just saw. It can be other living organisms. This is not a microbial infection or a mold overgrowth. You can't treat these people with antimicrobials or antifungals and expect them to get better and be cured. It doesn't work like that. It's not dependent on dose of exposure. So you don't have to live in a water damaged structure for 5 years before you develop something like this. It can be a very, very quick exposure. Your house could flood, doesn't get remediated. You start feeling symptoms within days of moving back in after that flood damage was taken care of. Of course, if you eat poisoned fish with ciguatera toxin, you can get that. Brown recluse spider, tick-borne, et cetera, on and on. So it doesn't have to be a huge exposure. Lastly, it's not an allergy or allergic response. So steroids, prednisone, antihistamines aren't going to take care of this either. And also another interesting point, this isn't just due to toxic mold in those water damaged buildings. You've got a lot of other molds that aren't toxic, or mycotoxins too, that aren't necessarily considered toxic, that can also set this off. Now, how does the chronic inflammatory panel differ? So we need to kind of step back and talk about what kind of inflammation are we actually talking about. And so the CIP, the chronic inflammatory panel, is a much broader but focused look at specific innate inflammatory response generated by those biotoxins. So we're really looking at markers of chronic inflammation. Now, other markers that we're all used to running, like CRP, RA factor, SED rates, interleukin-6, ANAs, etc., white counts, these are more often used to look at acute inflammation, so infections, or maybe even like prevention for heart disease, like we would use a CRP. These are not the inflammatory markers that we're looking for. And as part of your workup, probably for these patients, you're most likely going to be running these labs anyway. And more often than not, these are going to be, they're going to turn out to be normal or negative. So keep in mind that when you see this and you still have a sick person, perhaps think about biotoxin illness. Additional testing to think about. So we've already talked about how mold and mycotoxins can play an inciting role in biotoxin illness. Think about tick-borne illnesses, and our tick-borne 2.0 test looks at many of the co-infections that come along with Lyme disease, and also some of the other more prevalent viruses like the herpes viruses, Epstein-Barr virus, cytomegalovirus. So it takes a big, broad look at many of those infectious organisms. And then also consider heavy metals. Some metals can incite a partial innate immune response. So taking a look at all three of these tests as you go down that road of diagnosing your patient with biotoxin illness would be a good idea. Then, of course, using the chronic inflammatory panel to establish whether they do have that chronic inflammation, and using it as you monitor your treatment is a great idea as well. Last but not least, another test that's vital in your diagnosis of biotoxin illness is a visual contrast study. Now, this is basically an eye test to see how good somebody can establish or view contrast. Now, this is an old test. It's been around for about 50 years. It was developed by the US Air Force to actually assess for biotoxin exposure. So it's undergone lots of research. It's highly reproducible. It's very reliable. When you've got the 8 of 13, you've got symptoms in 8 of those 13 clusters that we've talked about before, and you get a positive test, this has a 98.5% sensitivity in diagnosing biotoxin illness. So this is something that you would do online. Here's the website for it. This is a quick test. It can be done in 15 minutes. The site will allow you to take this test once, or you can purchase a package of these. Like I said, this is a very important test in determining whether or not you actually have biotoxin illness. And so wrapping it up very quickly here, what is biotoxin illness? It is a progressive multi-symptom illness characterized by exposures to biotoxins. So remember, a biotoxin is anything that can be derived from any organism or a part of an organism that triggers an immune response, an innate immune response. And really, biotoxin illness is just that the innate immune system stays on. It doesn't pass the torch, so to speak, to the adaptive immune system. And Brooke talked about there are some possible genetic discrepancies or other issues why this might not happen in a person. And the big issue here is that this disease is not the exposure, it's actually the inflammation itself. And then lastly, how do you know if someone has biotoxin illness? You have to have that history of exposure. Those symptoms cannot be explained as a result of any other illness. So, of course, again, with these symptoms, you're going to have a very wide differential to start out with. You need to have those multiple symptoms and multiple systems, referring back to that symptom cluster that we shared earlier. Need to run that chronic inflammatory panel to know what those different cytokines, peptides, and hormones are doing, what level are they at. And then you also need to have that visual contrast sensitivity test. It's diagnosing biotoxin illness is a very complex process. It takes a lot of decision-making. There's a lot of rule outs, but we're hoping with this webinar this evening that you will be more aware of it. And now you've got some more tools and testing to utilize in your patients who, like I said earlier, present with a lot of different types of symptoms. And if they're not usually responding to your typical protocols, taking a look at the chronic inflammatory panel will help ideally discern whether or not they've got something deeper going on. All right, thank you for watching. Here is our references, and now we will start taking some questions.